So, welcome. Shown Falade Nwulia said she's actually done 3 talks, so you should know who she is by now. And you can read the bio. She's from Johns Hopkins, and we're going to talk about innovations in Pepsi care. Yorn? Thank you very much.
Good morning. How exciting to be here in Cape Town on this beautiful Friday morning talking about innovations in hepatitis C care. These are my disclosures. This is the outline. It's a lot, so we're going to race through. Put your seatbelts on. Since 2016, we've been working towards hepatitis C elimination. We want to treat 80% of people infected with hepatitis C so we can reduce new infections by 90% and reduce liver-related mortality. Here is our progress. This is a map showing proportion of people who inject drugs tested for hepatitis C antibodies across the world. So the dark gray are places where there's no evidence of injecting. The light gray, evidence of injecting, but no estimates on antibody testing. In red, areas with low prevalence of testing, less than 40%. Orange, moderate, 40 to 75%, and high, greater than 75% of people who inject drugs tested. So clearly, there's a lot of work to be done. This shows on the y-axis the proportion of people who inject drugs ever treated for hepatitis C, and on the x-axis, the proportion of people who inject drugs who have antibody positive for hepatitis C. Now, where do we all want to be based on this plot? I want to be in Spain, right? Because they have high rates of treatment of people who inject drugs and also a high prevalence of antibody prevalence. So why are we so far behind? There are multiple barriers at multiple levels that need to be overcome. System-level barriers. Very few places people who inject drugs feel comfortable or can even access treatment. Incarceration, criminalization continues to be a barrier to hepatitis C treatment elimination. We have very few providers because traditionally we've depended on specialists in a lot of settings. And at the individual level, there continues to be limited health information, stigma, fragmented healthcare systems, competing priorities, including housing, food insecurity, transportation barriers, and drug use. And so as we think about our approach to advancing hepatitis C elimination, I think really it's 3-pronged, right? We need to increase awareness and education. We need to expand access to testing and treatment. We need to treat people as people that have multiple needs and not just one infection. And we need to meet people where they are at. We cannot expect them to come to us, and we need to reduce stigma. And as I reflected on this talk, I'm like, innovation, what is new? What is innovative? Because really, is there anything new under the sun? So I went into the dictionary, and I looked up the definition. So innovation is improving or replacing something, bringing it up to date by applying new processes, implementing new techniques, or identifying new ideas to create something of value. I think as we think about innovation, we really should be reimagining our existing evidence-based interventions, point-of-care antibody and RNA testing, dried blood testing, telehealth, integrated care, medical chart audits, or we should be thinking about overcoming barriers to care in a new way. And I was so excited to come to INSU and hear this talk by Dr. Ajit Badoria, who has implemented self-hepatitis C antibody testing, drone transportation of blood samples for confirmatory HCV RNA, and then drone transportation of oral DA therapies from the pharmacy to the prisons. And the barrier that is being overcome is a very difficult terrain where people cannot travel. In addition, prisoners in jail or people in prison get access to specialized care for their hepatitis C via telemedicine. We talked about going to Spain. What is happening in Spain? Well, they have a really strong public health infrastructure, and in addition, there are programs like this that has been ongoing since 2017. It's a mobile hepatitis C screening unit where people can get point-of-care single-visit diagnosis of their hepatitis C. The program then provides services for hepatitis C prevention, hepatitis C diagnosis, and linkage to treatment off-site with a 70% initiation rate. This has gone a long way in supporting hepatitis C elimination because if you look at their data, over time, the prevalence of hepatitis C viremia has dropped significantly between 2017 and 2023. We have spent a lot of time at this meeting talking about the role of peers. There are a number of programs that have implemented peer strategies in innovative ways. This program from Oregon, USA stands out to me. It really has peers as the center of hepatitis C treatment. Peers recruit people who use drugs. They perform rapid hepatitis C antibody testing. They also provide a lot of support. They provide health system stigma navigation. They advocate for patients when the phlebotomy is challenging. The team also includes 2 internal medicine physicians, a physician assistant, a clinical pharmacist, and when patients are diagnosed with hepatitis C, they are linked to same-day, unscheduled telemedicine so that we are getting on-demand hepatitis C treatment. In addition, the intervention includes medication delivery and storage by the peers, adherence support, patients that are unstably housed get additional support, and they are also linked to substance use disorder treatment, harm reduction tools, and temporary housing. Because we want rigorous data, this was compared to enhanced usual care. The peers provided referral to local services. And these were their results. We see that treatment initiation significantly higher in the intervention arm, the folks that got tele-HCV, 85% initiated treatment compared to only 13% in usual care. And this translated to a cure rate of 63% in the telemedicine arm and only 16% in the usual care. I'm going to take a pause here because I know very often we get hung up on we need a 90% cure rate. But we need to recognize when we're working with our most vulnerable patients who are struggling with homelessness, right, we will, of a necessity, have some lower rates. Some of that is due to loss to follow-up, and some of that is due to reinfection. And now our job is to figure out strategies to overcome those barriers. This program, excitingly, after being shown to be effective in a randomized control trial, was immediately translated into a community-based program that is funded by opioid response dollars. It's been implemented in 18 of 36 counties in Oregon. So really moving quickly from evidence generation to implementation in real-world settings. And these are initial outcomes between 2021 and 2024 from this program. Again, we see that cure rate steady at around that 60% range. Another place people who use drugs sometimes access care are hospitals. I think models that are really looking at identifying patients who are hospitalized and linking them to care are important. This is one, including EMR identification, telehealth linkage, and financial incentives. They use the EMR to identify patients who have hepatitis C. Social workers do an assessment and refer patients to substance use treatment. The labs are done by the inpatient team and evaluation done by an internist with the outpatient pharmacy processing the prescriptions so that patients can get their treatments. In addition, to support the social needs, patients get prepaid phones and short-term medical hospital stays as needed. Financial incentives included $25 for evaluation, $50 for telehealth visits, and $100 for SVR labs. So in this pilot with 30 patients, we end up with 12 patients with SVR. So again, a cure rate around that 63% range. The other group of patients that I think we really do need to be thinking about, and we've talked a lot about in this program, are women. How are we meeting the needs of women? In this program, really focusing on women who are pregnant. This is really important in places in the US where the US opioid crisis has led to increases in hepatitis C in women of childbearing age. Our guidelines also recommend testing for hepatitis C with each pregnancy, and so we are finding that the prevalence of hepatitis C is high in this population. In this program, integrated into an outpatient perinatal substance use treatment program, where they also provide buprenorphine for opioid use disorder treatment and recovery support services. We have 5 OB/GYN, 3 nurses with addiction training, 2 clinical social workers, and 1 peer recovery specialist, providing integrated linkage to hepatitis C care. And what we see in this program is, again, we have drop-off rates. And a large reason this is happening is likely because we're waiting for women to finish pregnancy and then get treated later. I don't know anybody here who had a baby and immediately thought, I need to go for an outpatient appointment for my hepatitis C treatment. So not surprising that we see poor progression along the care continuum. And so it was really exciting to see this data presented here by Madeleine McRae, where they have a program using EMR identification of hepatitis C in pregnancy, hepatitis C care team outreach, and shared decision-making. So the US guidelines currently recommend shared decision-making, where as a clinician, you have a discussion with a pregnant woman explaining the pros and cons of hepatitis C treatment in pregnancy, and then giving them a choice. In this pilot, with 36 patients in antenatal care who were identified, 30 were reached, and 24 had a shared decision-making discussion, of which 75% chose to have their hepatitis C treated in pregnancy. Amongst these 18 individuals, only 1 person did not start treatment, and that was because their insurance did not approve treatment. They were treated using standard of care with the medication that was covered by their insurance. And we see in this care continuum that 82% of women who were pregnant, treatment started in the 2nd or 3rd trimester of pregnancy, 82% of them achieved SVR4. The SVR12 rate is lower because women haven't gotten to the 12-week post-end of treatment time point. But we do know that SVR4 very often is equivalent to SVR12. So again, I think this is a big step forward and a big victory in our approach to addressing hepatitis C in pregnant women. And we saw some data yesterday presented by Catherine Chappell, really showing that hepatitis C treatment in pregnancy in a rigorous clinical trial continues to be safe with good outcomes, both for the mother and for the baby. We're bringing it home to South Africa, and I have to say this is probably one of the most impressive studies I saw. Really thinking of people as people who have multiple needs and integrating the needs in one program. So this is a community-based integrated point-of-care test and treat program where they are using point-of-care to test for hepatitis C, hepatitis B, and HIV. It's in the community. Community workers and peers, again, are doing a lot of the heavy lifting. Patients get their follow-up testing quickly, and they get same-day test and treat, same day as we try the best we can, but it is a test and treat model. In this model, they screened 213 patients in less than a year. 174 were antibody positive, of which 88% got tested for RNA, 90% of those tested were viremic, 72% were treatment eligible. And this is because for individuals that were newly diagnosed with HIV, they prioritized initiation of antiretroviral therapy. And for individuals that were also found to have hepatitis B, they prioritized treatment for hepatitis B. Now, of those that were treatment eligible, 95% initiated hepatitis C treatment, 84% completed treatment, and of those, 83% had an undetectable RNA at end of treatment. Now, I will note that there was a high rate of loss to follow-up. 41% of individuals that started treatment could not have SVR confirmed. So we see this ongoing theme of loss to follow-up, but again, if majority of people completed treatment, we're going to assume that majority of those individuals achieved SVR. The median time to hepatitis C treatment initiation was 2 days, so kudos. I'm going to shift gears and talk a little bit about some work we've done in Maryland through a public-private partnership between Johns Hopkins University, the Maryland Department of Health, and our local SSPs. So the plot you see is a heat map showing hepatitis C prevalence across different counties. So the darker, the higher the prevalence of hepatitis C. So lots of specialist care in the academic centers, but very few providers in the rural areas. And so through this program, we as telemedicine providers have worked to partner with SSPs to create private telemedicine-equipped locations to conduct telemedicine video visits. The patient comes on site. One of the barriers to care is very often patients don't have devices to get on telemed. So patients can come to the SSP. They can have the support of a peer to connect to their telemed appointment, to provide case management. We have nurses who are off-site and work with the patients largely via phone and then through the peers at the SSP, and then we provide integrated opioid use disorder and hepatitis C care. So incredibly grateful and thankful for the on-site peers, again, who do most of the heavy lifting. And so I want us to begin to think about our interventions in terms of strategies so that we're using the same language so we can learn from one another. So the strategies we used in this program were identifying and preparing the champions. Who were the champions at the SSPs? Who wanted to do this work, and how did we support them to be able to integrate hepatitis C testing and treatment into their locations? We trained the staff to engage participants, the peers, who the SSP participants trusted, engaged the patients, and then we provided ongoing technical assistance to ensure that the programs were working well, and then monitored implementation. One of the things that is really important as we implement these programs is that we make sure that they are acceptable, they are appropriate, they are feasible so that they can be sustained long term. So pre-implementation, we measured this and noted high rates of acceptability, appropriateness, and feasibility. And so in the first 3 years, we had 291 patients that were referred to the program. I think what we are most proud of is that 50% of the people that were referred to our program were women. So it is so exciting to be able to meet the needs of everyone that needs hepatitis C care. The plot shows the care continuum of those that were found to be RNA or hepatitis C viremic. 94% attended the telemedicine visit. 91% of them initiated DA treatment. 93% of the first group completed treatment, and where we really see drop-off, again, is that confirmation of viremia, right? Only 60% of individuals came back to get SVR12 assessment, but so exciting that every single person that came back was cured of their hepatitis C. And as we think about approaches to address loss to follow-up and ensure that our patients can continue to reap the benefits of the care they've received, I'm very excited to start our newest clinical trial, again in partnership with the SSPs. It's a hybrid type 1 effectiveness RCT, which is funded by the NIH. We're assessing the effectiveness of a network-based intervention to increase uptake of hepatitis C, HIV, and opioid use disorder care provided via telemedicines at SSPs in rural Maryland. We're going to look to characterize implementation processes and outcomes, including acceptability, fidelity, and reach. So what exactly are we doing? So we already have this SSPs where people feel comfortable accessing care with staff they feel comfortable with. We had a really fun time co-creating a social network intervention with people who use drugs at the SSP and the SSP staff and local community members, so that our intervention allows SSP staff to identify people who are already accessing care at the SSP and train them to become peer mentors who go into the community to support their network members to engage in hepatitis C testing, HIV testing, and HIV treatment, PrEP, or opioid use disorder care, as indicated. We've talked a little bit about implementation science, so I want to bring to your attention this recent commentary by Guillaume Fontaine and others. I'm really trying to bring attention to the benefits of using implementation science approaches as we implement our programs. I think one of the things that I think implementation science will really allow us to do is use frameworks to adapt hepatitis C interventions or implementation strategies to different cultural or regional needs, and also to increase our ability to implement, spread, scale, and sustain interventions. I cannot stop this talk without talking about the excitement that is generated about the UNITAID-funded path-led hepatitis C prevention in people who inject drugs and prisoner projects. I'm really looking at treatment as prevention among people who inject drugs and people in prison in India, Nigeria, South Africa, Ukraine, and Vietnam. Lots of innovative things here, including helping us to understand how to shape the market for underused hepatitis C prevention, diagnosis, and treatment tools, extensive key stakeholder engagement, including co-creation of these interventions with people who inject drugs, people in prisons and community, and actually having the communities most affected be part of the implementation process. And the eventual goal of effective transition and scale-up of hepatitis C prevention and treatment services for people who inject drugs in prisons. So in conclusion, there are several interventions that are proven effective for increasing hepatitis C awareness and treatment. We're going to have to scale. We're going to have to implement widely, and we're going to have to move quickly. Innovation lies in reimagining implementation of existing interventions. We're going to have to think about contextual factors and integrate them in our approach to implementation. And I do think implementation science really does give us some additional tools to do that effectively. I want to thank so many people, the patients who have taught me so much, my study participants, the people who use drugs that I have partnered with in all my work, SSP staff, community members, the people that fund the work and hopefully will continue to fund the work, and the people and the amazing staff I work with at the Center for Substance Use and Infectious Disease Care Integration. And thank you all for listening.